Tests for antibodies, or serological tests for SARS-CoV-2, have come a long way since the early days of the COVID-19 pandemic. There are now several commercial tests available, and some laboratories have developed tests for specific purposes. Serological tests can determine whether a person has had COVID-19 in the past, or whether someone has had an antibody response to vaccination, or even whether somebody has antibodies that can neutralize the virus, preventing it from infecting host cells. Welcome to Editors in Conversation. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org and on Twitter at jclinmicro. I'm your host, JCM Editor-in-Chief Alex McAdam. This podcast is supported by the American Society for Microbiology, which publishes JCM. I'm joined by two expert guests to discuss serologic testing for SARS-CoV-2. First, Dr. Elitza Theel, who is the director of the Infectious Diseases Serology Laboratory at Mayo Clinic in Rochester, Minnesota. Dr. Theel recently began a term as an editor of JCM. Welcome, Ellie, and thanks for being here again, a third time.
Thanks, Alex. Happy to be here.
We're also joined by a first-time guest, Dr. Alex Greninger. Dr. Greninger is the assistant director of the Clinical Virology Laboratory at the University of Washington, where he's also an assistant professor of laboratory medicine. Alex, I'm pleased to welcome you to the podcast.
Thanks, great to be here.
Dr. Theel and Dr. Greninger each have a paper about serology for SARS-CoV-2 in press at JCM, and these will be published in their final form in a month or two. We'll put links to the accepted manuscripts in the show notes. Ellie, let's start with you. There are several different types of tests available for antibodies to SARS-CoV-2. Can you give us an overview of the uses of these tests?
Sure. So there's generally two types of antibody tests that I kind of think of. So there's your total binding antibodies versus those that detect the specific functional neutralizing antibodies. And so for the common binding antibody assays, they've been designed to detect either nucleocapsid or spike or receptor binding domain antibodies, which really prior to widespread vaccination could be used somewhat interchangeably to detect prior infection with the virus. With the introduction of vaccines, however, which are all based on stimulating an immune response to the spike and receptor binding domains, it gets a little more complicated since detecting antibodies to the spike or RBD won't differentiate between vaccine response versus prior infection. But in a previously vaccinated individual, if you detect an anti-nucleocapsid response, you'll still be able to determine whether or not they've been previously infected. And so,
No, please go on.
Yeah, so that's the binding antibodies. And then there's the neutralizing antibody assays, which, classically they're detected by plaque reduction neutralization assays and pseudoviral neutralization assays, which are really challenging to perform, tedious to do. And so alternative surrogate neutralizing antibody assays have been developed, like blocking ELISAs, which are based on the ability of sera to block binding of recombinant RBD to recombinant ACE2 receptor in an in vitro format. And so these can be automated and easily performed. Their neutralizing antibody assays aren't really widely used in the clinical lab. Still, really one of the current goals, I'd say, in the COVID serology field is to determine whether we can identify a correlate of immunity to the virus, potentially based on detecting these neutralizing antibodies, similar to what's been done with other vaccine preventable diseases. So I'd say that's kind of a general overview of where we are with serologic assays currently for COVID.
Perfect. And we'll get into a little bit more about some of those specific categories, I think, as we go along. I always feel a little silly reading the title of their paper, but it's part of it. Ellie, your paper is titled SARS-CoV-2 Serologic Assays Dependent on Dual Antigen Binding Demonstrate Diverging Kinetics Relative to Other Antibody Detection Methods. And in it, you addressed how levels of antibodies to the virus change over time after SARS-CoV-2 infection. Can you give us some background into what was known about this before you began your study?
Sure. So we know that following any acute infection, antibodies to various pathogens, including the other common coronaviruses, that antibodies naturally decline over time. But what we found interesting prior to our study was that there seemed to be some conflicting data being reported on the duration of antibody positivity to SARS-CoV-2. and specifically following natural infection. So this was before vaccines were put out. And I guess, although we know that duration of antibody positivity is a function of multiple factors, right? Like initial disease severity and the individual's immunocompetence. It seemed that these studies, when using similar COVID patient populations, some studies were reporting rapid decline in antibody levels over time, like 3 to 4 months after infection, whereas other studies suggested that there was more of a plateau in antibody levels at about 2 to 3 months, and then minimal declines over the subsequent 3 to 4 months. So seeing that all of these studies were done with a variety of different assays, we were curious to see what we would find using a single set of longitudinally collected samples that were tested across a variety of different serologic platforms.
And just to back up, and perhaps I should have asked this first, why do we care? What does it matter how long the antibodies last after infection?
Yeah, so that's a good question, and I think it gets back to the basic question of why do we use serologic testing for COVID in clinical labs, right? I think we would all agree that there's definitely a role for serologic testing in research, identifying that immune correlate of protection. But in the clinical setting, I think it's still somewhat unclear exactly how best to use these assays. That being said, a lot of individuals, a lot of clinicians are still ordering serologic assays. So I think we need to know how they perform and how long antibodies are detectable over time, because I think it may become important further on in the pandemic.
Good. Let's get back to your study. Just take us through the design of your study before we start talking about what you found.
Yeah, so it was a pretty, I think, straightforward design. We identified 44 COVID patients who had recovered in the outpatient setting and had donated plasma at least twice over a 4-month period. And then so we ended up with 106 residual sera from those individuals, and we tested them on 8 different serologic assays, 6 of which had FDA EUA, 3 were anti-spike IgG or total antibody assays, 2 were anti-nucleocapsid, and then we had the Genscript CPAS assay, which is a surrogate neutralizing antibody test. And then there were 2 other non-FDA assays, both detecting neutralizing antibodies, one using VSV-based pseudoviral neutralizing assay we had up and running at Mayo, and then another second surrogate neutralizing assay that was chemiluminescent based. And so after all that testing, we basically looked at qualitative concordance between the assays, and then more importantly, trending of the signal to cutoff values or antibody levels as detected by the assays over time.
Can you tell us a little bit more about the pseudotype vesicular stomatitis virus assay? That seems to be the most common surrogate neutralizing antibody assay that I see, and I think people may be curious to know how it works.
Yeah, so I think there's multiple different designs for the assay, but it basically is taking vesicular stomatitis virus that expresses the spike protein. And so it's a BSL-2 level virus. You then mix it with either serial dilutions of your serum, or you can use a standard calibration monoclonal antibody curve. But you mix it with your serum, and then you put it over susceptible monolayer expressing the ACE2 receptor. And so you can envision, if you have neutralizing antibodies, they'll bind to the spike protein on the VSV and inhibit its binding to the ACE2 receptor, so you won't have plaques or you won't have activity detected. Whereas if you don't have neutralizing antibodies, you will either detect plaques or detect some sort of signal over time.
And why do that instead of just do a neutralization assay with SARS-CoV-2? Is it the containment, or is it a more reliable assay?
Yeah, so it's primarily the containment. So SARS-CoV-2, consider a biosafety level 3 assay. Few labs have BSL-3 level containments, and even fewer probably want to put up a plaque reduction neutralization test for it at this point.
Got it. So let's see. You had 3 different tests for neutralizing antibodies, and we've talked in a little bit of detail about one of them. Why did you have 3 different tests for neutralizing antibodies?
Yeah, so one of them was, again, the Genscript CPAS assay, which had FDA EUA at the time. And we were actually in the process of evaluating it relative to our Mayo VSV pseudoviral assay. And then the third one was a recently developed quantitative RBD ACE2 inhibition assay based on alpha ELISA chemiluminescent technology, which uses very little volume, and it's a fairly quick and straightforward assay to perform. So we included all 3 because we really wanted to see and ultimately show how these fairly different neutralizing assay antibody detection methods compared and performed relative to one another, in the hopes that we could move away from the complex pseudoviral assay that we were using at the time. Ironically, right now, we are actually not running any neutralizing antibody tests, but at the time, we were interested to see if we could bring in a quick and easier assay, since we were doing a lot of convalescent plasma testing.
And what was the decision around not offering such a test, not doing an assay for neutralizing antibody?
So one was requests for testing really went down once convalescent plasma use kind of dissipated over time with the introduction of monoclonal antibody therapy. Really, the major request for testing was coming from vaccine developers and manufacturers, so not so much from the clinical lab.
Got it. All right, before we get to the changes in levels of antibody over time, and I promise we will get there soon, were each of the different tests that you looked at sensitive for detection of previous COVID-19 infection?
Yeah, so I'd say with the exception of the alpha ELISA surrogate neutralizing assay, both our lab and many others at this point have shown that the major FDA EUA assays that we used had over 95% sensitivity at detecting prior infection in patients who were tested at least 10 to 14 days after confirmed infection or symptom onset. And so, yeah, I'd say they were very sensitive. And in fact, even at the final time point in our study, only 4 patients seroreverted to negative, 3 by the Abbott and 1 by our assay. So they were fairly sensitive assays, I'd say.
Okay. So let's get to it. Can you give us a summary of how the levels of antibodies changed over time in the people who were tested after recovery from COVID-19?
Yeah, so bottom line, what we found was that antibody levels for the semi-quantitative assays that we had, as well as the signal to cutoff levels for the qualitative assays in our study, they significantly declined over that 4-month period for 6 of the 8 assays that we looked at, including all 3 neutralizing antibody assays, as well as the anti-spike and anti-nucleocapsid binding antibody assays from Abbott, Euroimmune, and Ortho. So this decline in antibody levels was not seen for the 2 Roche electrochemiluminescent-based immunoassays, which interestingly showed a significant increase in both signal to cutoff or in the unit per ml numerical outputs for their nucleocapsid and receptor binding domain assay. So that was basically the bottom line of the study. Interestingly, or importantly, the 6 assays that showed decreasing levels over that 4-month time period, as I kind of mentioned, they still remain qualitatively positive for the vast majority of patients, But the question remains, what would happen further out in time past that 4-month time point? Would they serorevert to negative or not? And unfortunately, I'd say that's one of the limitations of the study. We really couldn't look beyond that 4-month time point simply because there were no more samples.
Got it. So we've got 6 tests that say that the level of antibody falls over time, and 2 tests, both by the same manufacturer, that say that levels of antibody rise over time. What is special about those 2 tests? And give us a little bit of detail about how those tests work and how they differ from the others.
Yeah, so I guess I'd have to say I don't have a definitive explanation, right, for why we're seeing that difference in antibody trending between Roche and the other assays. But one of the things we really suggest in the paper is that one of the main reasons could be method related. So the Roche assays, both of them are based on a dual antigen bridging method to bind and detect antibodies. So each antibody in the sample has to bind to both a recombinant RBD or nucleocapsid antigen that's labeled with ruthenium, as well as bind to a recombinant RBD or nucleocapsid antigen that's biotinylated. So again, each antibody has to have both binding reactions to occur in order to be detected by electrochemiluminescence. So that's in contrast to the other immunoassays, which are primarily sandwich-based assays requiring a single antibody-antigen interaction for that antibody to be detected. So you can envision how perhaps that dual antigen binding requirement, in addition to the fact that chemiluminescent-based assays are maybe a little bit more sensitive than other methods, how those 2 things could be playing a role in the antibody trending differences that we observed. So
just to back up a little bit, most classes of antibodies have 2 binding sites, setting aside IgM, and let's please set aside IgM. 2 binding sites, and usually only one of those binding sites has to be occupied for the assay to score as positive. But in this case, both binding sites have to be occupied for the assay to score as positive, because that's what leads to the signal. Is that right?
Yep,
all
that's
right. And that
description.
All right. And the thought is that it is something about affinity of the antibodies, or what give us a little more about why these 2 assays gave you such surprisingly different results.
So
and I know we're in the world of speculation. That's fine.
Okay, good. So the idea we have at this point is that this dual antigen binding method preferentially is pulling out high affinity, high avidity antibodies, which typically take longer to develop and mature, but they're produced by longer lived plasma cells. So that's in contrast to the other immunoassays, which again typically require single antigen binding, and so are not as stringent in their binding requirement. So then in addition to binding high avidity antibodies, they're likely detecting kind of all-comer antibodies, including those with lower affinity and lower avidity, which are typically produced kind of en masse by relatively short-lived plasmablasts. So once those plasmablast cells reach their peak early on after infection, those lower affinity and avidity antibody levels begin tapering off, which is perhaps what we're seeing reflected by the non-Roche-based immunoassays.
Got it. Thank you. Can you give us just an overview of how well the results of the 8 assays correlated with one another?
So overall, what we saw qualitatively, all assays agreed very well with each other, which was not unexpected. But when it came to the numerical output of these assays, although I'd say we saw maybe some correlation between the spike-based ones, the nucleocapsid-based numerical output really poorly correlated with the remaining assays. And I'd say, again, overall, given the lack of standardization between serologic assays, it wasn't entirely unexpected, and really argues for the need to start harmonizing these assays, particularly the quantitative ones, which some manufacturers have started to really focus on. And I think we have our first serologic assay that is standardized to the WHO standard that came out with FDA EUA, I think last week. So we are starting to standardize.
Excellent. Let's turn to your paper, Alex, and Ellie, jump in if you have questions as we're going along. The title of the paper is Anti-SARS-CoV-2 Antibody Levels Measured by the Advised DX SARS-CoV-2 Assay are concordant with previously available serologic assays, but are not fully predictive of sterilizing immunity. That's the title, not the abstract. You studied the Advised DX SARS-CoV-2 assay in a lot of detail, comparing it to several other tests. And I guess I assumed in reading the paper that it was a test you were checking out for possible use in your laboratory. And if that's the case, what are the features of the test that made it promising?
Yeah, we were looking at the Abbott anti-S, which is one of the ones that Ellie evaluated as well, largely because those are the analyzers we typically use. There's a lot of Abbott architects and now these Alinity analyzers out there. And so we wanted to see how this test would perform. And then, of course, we compared, similar to what Ellie did, with comparing it to the Roche anti-S, as well as the Euroimmune anti-S, and then the CPAS as well, the surrogate neutralizing antibody test. And I guess those Roche and Abbott ones are both RBD, technically. But mostly it was really because of the analyzers we've traditionally used for, HIV, hepatitis B, and hepatitis C.
Thank you. And I think it makes a point that we've probably discussed on the podcast before, which is appreciated, I think, by everybody who works in the laboratory, but may be news to some of our colleagues in other related fields. And that is that when we are choosing an assay, we often go after the one that goes on the platform that we already own, right? Because we have a reliable platform, we don't necessarily want to go chasing after a new one unless we have to.
Unless you're Mayo and you have like 10 platforms and you're just like, it's really just it's like, what you're feeling that day,
You've got pretty good resources at UW too, I think. So how did the Advised DX assay work when you performed it with the samples from people who had previously had SARS-CoV-2 infection?
Yeah, and we found similar thing in terms of qualitative tests. It does just fine. We were finding like 95%, 96% sensitivity at sort of day 14, which is kind of it's a helpful cutoff to have, a cutoff to draw a line in the sand after symptom onset. But two other people like went seropositive a day or two later. So it's hard to know like how to count those towards like sensitivity calculations. But typically they say, okay, day 14. So it's, as Ellie said, it's above 95% in terms of qualitative sensitivity. It also has a pretty large dynamic range, probably because it's picking up some of those low affinity antibodies, as Ellie said as well. So, it's a decent one, but I think what's really important is, honestly, I want to really give a shout out to Ellie's paper. I think it's a really, really important paper for serology to find, basically because, we honestly put out a high profile paper on the Abbott anti-N test about a year ago in JCM, and it has not, we evaluated a test, 2 months after the virus came out in Seattle, and the assay looked fantastic. And if you fast forward, or you go forward 2 or 3 months, which you couldn't do at the time, right? You can't, run future samples. But the performance of that test has dramatically changed. It's been shown over and over and over, sort of most impressively, actually, in a paper from LabCorp looking at all of their results, where the sensitivity of that assay is now sub 50% if you're going out a year. And so those quantitative declines in values to signal cutoff have real implications for qualitative, and they certainly have implications for what the quantity is. And so, figuring out those, if you're that's just the first order, right? If you're even going to take it to the next level, what's a surrogate, for protection or correlative protection, we've got to get this sussed. And I think that's actually one of the things that I've learned the most about from these assays in the last year, and especially I think that's why that paper from Ellie's group is so impressive in terms of trying to work out some mechanism there, and really how potentially superior the Roche assay is to this. So I just thought I'd want to come back and sort of give a shout out to everything that is sort of covered there. And the too long didn't read is the Roche assay works better qualitatively, it seems.
Yeah, and the paper that you mentioned, that high profile paper about the Abbott assay, has been downloaded tens of thousands of times, more than 100,000 times. And it really sort of was one of the emblematic early serology papers in the field. And we're going to come back to another one of your papers
wrong
in just
now.
a few minutes. You want to write us a letter?
Call it what it is. I mean, like, it was right at the time. It's really hard. It's really hard to do this. I mean, right? You can be right at the moment, and then in the future, it's not wrong of what it was, but it's just, you know, it changed, and that's what it is.
It was correct then, but
totally
now
correct. It's still correct, but
well,
it's right as of 1 month after you get infected. The Abbott in is great. The problem is that now a year forward, we don't get to choose when you were infected. We kind of got to choose that in May of last year.
Think about writing us a comment letter, and I'll sign it to Ellie.
Oh, okay. All right. Yeah. I'm winning a lot of friends here already.
Let's see.
Sorry, I derailed you.
I just want to back up.
There, yeah.
I know you. That's all right. We got off onto some other interesting stuff, and that's fine. So, how well did the Advised DX assay perform when you looked at samples from people who were previously infected with SARS-CoV-2? Did I already ask you that?
Yeah. This is greater than 95% qualitative sensitivity. There's a wide range of responses that people have, especially relative to when you test for them, which is both biological and assay dependent.
Yep. And you'd also found that the Advised DX SARS-CoV-2 assay had results that correlated well to those of 3 other assays. And I want to focus on the comparison to the Genscript surrogate virus neutralization test, which we've talked a little bit about already. And again, that's the one that's the FDA EUA approved assay for neutralizing antibodies. So how did those 2 tests compare?
Yeah, I mean, they compared pretty well qualitatively. I mean, that's the weird thing about the Genscript CPATH assay is that it's a neutralizing antibody test, but it's fundamentally it's got a qualitative threshold. It's not super quantitative. It's not really authorized for quantitative use. And they basically, one of the interesting things I thought is, so what we did find is we found a few more positives with the Abbott. The Genscript came in with like a sensitivity of like 90%. Compared if you look at the Abbott, and a lot of those other samples were positive on other platforms as well for the discrepance. And I think what was interesting there is kind of a little bit of a silly thing, but it's really important is what thresholds people choose or what companies choose for their positives. And so actually, when we had originally evaluated the Genscript like almost a year ago, before they had an EUA, they had a 20% inhibition counted as a positive. And then when they got the EUA, they moved their threshold up to 30%, and almost all of our discrepants were people who are probably going seropositive or whatnot, but they were right at that sort of cusp, and that pushed most of the discrepants. Over half the discrepants were in that 20 to 30% range for the Genscript. So by changing their threshold, they kind of hurt themselves in this particular context. But those surrogate neutralization assays can be a little finicky. Because they're not usually on a perfectly automated analyzer. And so there's a lot more pre-analytical factors that go into them.
So when they changed the cutoff, you said that they sort of reduced the performance of the assay. Was it loss of sensitivity
of it? Well, they probably had to trade it off for some specificity. So, for these particular assays, we didn't do the FDA packages, they test 2,000, 5,000 negative samples. I mean, we're not doing that here. We're really trying to understand where they work or don't work or compare in their quantities on a sensitivity level.
Gotcha. And speaking of sensitivity, and this is turning, I think, from clinical sensitivity to analytical sensitivity, but correct me if I'm wrong. You use the WHO international standard to look at sensitivity. And before we get into what you found with that, take us through what that standard is.
Yeah, so the WHO, or a group of people that call themselves the WHO, bet at the WHO, and put the imprimatur of the WHO on it, have an international standard for about 11, I think it's pooled plasma positives that are now being sent out and can help standardize. So Ellie talked briefly about sort of standardizing these assays. And so we use that basically to compare in dilutions of that material to see both how to adjust the arbitrary units for each of these assays to international units, as well as to look how the qualitative thresholds worked in the context of that standardized material. And so, we found basically in that one, the Roche was actually the most sensitive of the four assays that we looked at with this. The Abbott and Roche were very similar in the anti-RBD quantitative. The Abbott anti-N was significantly less sensitive, though. That can be both because of the assay design, as Ellie's pointed out, as well as it's an anti-N assay. So they're sort of different antibodies to each of those. And then the Euroimmune sort of came in the middle between those guys.
Gotcha. And you also looked at samples from a small number of people who were protected from infection with SARS-CoV-2 by a previous infection with the virus. as well as some samples from people who became infected more than 4 weeks after their second dose of either the Pfizer or Moderna COVID-19 vaccine. What were the results of looking at those samples?
Yeah, so this was probably one of the more interesting parts for this study, is that we were able to look at these breakthrough infections, as well as people who were on this fishery vessel previously, also published in JCM, who were protected from infection. And that's sort of the rub of it, is basically the people who had breakthrough infection had, so these were individuals who they had breakthrough infection, were symptomatic. We got blood from them and were able to test their response, their antibody response, and they were anti-N negative, right? So we got them before they made what we think was a response to the current infection. So we think we're capturing what their sort of serological profile was when they were infected. And all these individuals had detectable anti-S, and not just detectable anti-S, they had high levels of anti-RBD antibodies, 1,000 to 10,000 arbitrary units per mil on the Abbott. And if you compare that, which is actually, we had a vaccinated cohort as well, which is they had a pretty good response. They weren't like at the tip top of their antibody response by any means for people who were vaccinated, but these were really decent responses, and they still had breakthrough infection. And we also looked at some people who were protected in the fishery vessel outbreak, and they had basically 1,000 to 5,000 arbitrary units per mil. And so that's like basically the overlapping populations, which really gets to sort of the heart of the issue for a lot of these assays, which is that there's no perfect correlate of protection, and there's no correlate of sterilizing immunity, which means there's no, that you're completely protected from ever being PCR positive, let alone symptomatic. And then what's more is the virus that's circulating right now, or the viruses that are circulating right now, are not actually captured by these antigens that we're testing the immune response against, let alone the vaccines that we're vaccinating with. And so all of those sort of come together and sort of form this sort of, the way that serology tests are used less. At the same time, we're now seeing the correlates of protection come out from the large vaccine studies, showing us what we expect, which is that the stronger the immune response, the higher the titer of antibody that you have against, the more likely you are to be protected. So, that was kind of a way to illustrate that on sort of a smaller subset of people who had breakthrough infection and people who are protected.
Great. So let me ask both of you, and I'm going to start with Ellie, because Alex, you've already waded into these waters, but you may have more to say on the question. Which of the many tests that we have been talking about do you think best predicts immunity from COVID-19? And I mean prevention of infection or prevention of severe manifestations, you pick. And if that's the wrong question to ask, tell me why it's the wrong question. And again, we'll start with Ellie.
So I think it's a tough question. If we are talking about which assay best detects an immune response and best quantifies an immune response to vaccine or past infection, I think the anti-RBD, so your Roche and Abbott anti-RBD assays are probably best. But because you can get breakthrough infections, because we're seeing those infections in vaccinated individuals, I don't know that we can definitively rely on these assays to tell us you're protected from reinfection if you're positive. I think we can say that if you have a strong immune response, you're less likely to get infected, less likely to be symptomatic. But I would caution against saying that you are definitively immune from reinfection because you have a high positive response on one of these assays. All
right, so one thoughtfully qualified vote for anti-RBD. How about you, Alex? What would you say?
I'm the unqualified, the unthoughtful shotgun approach to commentary here. No, so I mean, I think I would go. If you're giving me a unicorn, I'm going to take the unicorn, which is I'd rather have the pseudovirus neutralizing antibody or viral neutralizing antibody tests at like a high, like an ND80, so 80% inhibition. So you're sort of getting at some of those top line antibodies. That seems to be in some other studies a slightly better correlate of protection for some of these things you've seen. The AstraZeneca, the Oxford group put out the AstraZeneca correlates of protection. So they found like an ND50 of like 185. So a dilution of 185 that blocks the 50% of the infection is a pretty good correlate of protection. But from a workflow standpoint, our workhorses are going to be these binding RBD quantitative assays. I would like to see them get used more, though. I mean, I think that's the thing. I think we're definitely seeing that, and I'd love to hear what Ellie's experiences are in the context of immunocompromised individuals, people who are not part of these vaccine trials, where we really don't have a great evidence base for what's going on, and so we kind of have to put our thinking caps on, as well as our laboratory assays on, and use those to sort of try to figure out what's going on here before we have data and while we've got to help people.
Yeah, I mean, if I had a good neutralizing antibody assay that I could automate and not have to serially dilute out and worry about standards and whatnot, I would take it, definitely, but we don't have those. And I think what's been shown is that the current binding antibody assays, they don't really seem to correlate well with neutralizing antibody titers, regardless of what neutralizing assay you're using. So I think that's going to be an ongoing challenge, maybe. And then to get to your question about immunosuppressed patients, yeah, we're seeing many of them are fully vaccinated and 4, 5, 6 weeks out are still seronegative. And so, there's ongoing trials now talking about booster doses for those patients. I'm not really convinced that that's going to help necessarily, but you got to try it. And I think there's a country now, right, in Europe somewhere, France maybe, where they are providing 3rd and 4th booster doses for all of their immunosuppressed patients. So it'll be interesting to see whether that really manages to stimulate some sort of immune response in them.
Great. What have we missed? Anything else we should talk about?
I have a question on the Roche assay where you work on, Ellie. So is all of the binding between those two, the dual bridging, is all of that binding done in solution? Or is any of it done, I mean, when they basically captured on a magnetic bead, might it be more than just the high affinity antibodies, and that actually you're able to trap on a physical surface, and so actually your low affinities the antibodies don't get to walk off into solution and sort of stay bound to one side?
Yeah, so my understanding is that the dual binding to both happens in solution, and then it's bound to your particle, so everything else is washed away before, really limiting that low affinity binding to the particles. My understanding.
Yeah.
But, yeah.
It would be fascinating to understand how those measurements, I mean, qualitatively, they work quite well, because we sort of know once, if we're trying to say, have you been infected with SARS-CoV-2, that's a binary yes, no. And once you go into the yes category, you don't go into the no category. So they work quite well there. But it'd be interesting to understand how the quantities that come back are predictive of protection in that context.
Yeah, definitely. I think it's, amongst all of the studies that are ongoing, that's kind of towards the top of the list, and also proving whether this avidity affinity thing is really true or not. So treating those samples with urea and seeing whether we see a differential release of antibodies.
Tell us a little bit more about what the significance of treating with urea. I think that may be new to a number of listeners.
Yeah, so the classic way to detect high avidity antibodies, whether it's for COVID or toxo or CMV, would be to take your serum sample and treat it with, I forget what molarity of urea. But basically the urea would, if you have a low affinity antibody that's binding to an antigen and you treat it with urea is going to cut or break that binding. Versus if you have a high avidity, strong binding between antibody and antigen, that the addition of urea will not dissociate the binding. So you can measure the different levels of signal intensity with and without urea to determine the level of avidity.
And you mentioned toxo, and I think I am familiar with that as a clinical assay for affinity. Are there other antigens or pathogens for which affinity assays are significant?
Yeah, so toxoplasma and CMV are the biggies. Particularly in pregnant women, to kind of determine whether or not infection occurred recently or not. So typically low avidity antibodies are considered to, the infection is considered to have occurred within 3 to 4 months previously, although some people can have low avidity antibodies for years. Whereas if you detect high avidity antibodies, the thought is that infection occurred at least 3 to 4 months prior. So based on that and timing of pregnancy, you can kind of help determine whether this is pre or post infection, previous or during the pregnancy.
Thank you very much. We've wandered off the path a bit, but it has been extremely interesting. This has been a great conversation. I want to thank you both for joining us on Editors in Conversation.
Thank you.
Thank you.